Hey, Margie here. There's so much confusion and misconceptions when it comes to estrogen. I was very lucky to interview Dr. Felice Gersh on the Natural Approaches to Osteoporosis and Bone Health Summit. And she really cleared this up for so many of us. But people wrote back with questions. And so today, in this podcast episode, I asked Dr. Felice to come back and I asked her the questions because there's so many valuable nuggets in the information that she provided. So today is full of really, really wonderful information. But let me just tell you a little bit about Dr. Gersh. She's a multi-award winning physician with dual board certifications in OB-GYN and Integrative Medicine. She's the founder and director of the Integrative Medical Group of Irvine, which provides comprehensive healthcare for women by combining the best evidence-based therapies from conventional, naturopathic, and holistic medicine. She taught obstetrics and gynecology at Keck USC School of Medicine for 12 years as an assistant clinical professor. She now serves as an affiliate faculty member at the Fellowship in Integrative Medicine through the University of Arizona School of Medicine. Dr. Gersh is a best-selling author and a prolific lecturer. She has given talks and webinars to doctors throughout the world, been featured in several films and documentary series, and has written multiple medical articles that have been published in prestigious medical journals. And I've known Dr. Gersh for many years and just love the work she does. And she's done so much to contribute to the world of bone health. So stay tuned for lots of great information. Welcome, Dr. Gersh. I can't even tell you how happy I am to have you here and so appreciative. Here you are in Nashville at a conference on hormones, and you've actually taken the time to answer people's questions and to be on the podcast with me. So thank you so much. I so appreciate this.
Well, it's my pleasure. I'm sorry, I just had a little siren outside, but that's the way it is in a big city. But it's absolutely my pleasure to join you and to help answer the questions that your viewers had after the summit.
Yes. So they had so many really amazing questions. And I really thought I was trying to figure out the best way. And I said, instead of just writing the answers and having, sending it out as an email, why don't you come on the podcast and we can share this with everybody, because this is so important. The topic of estrogen and hormones that you talked about on the summit is something that's really not discussed a lot in conventional medicine. And there's just so much confusion. So I'm just going to start off. I'm asking you all the questions that were asked after your talk during the summit. So you ready? We'll just get started.
Oh, absolutely.
Okay. So the first question was, I was on hormone replacement and I got endometrial cancer. My doctor made me go off hormones after my hysterectomy. Can I go back on estrogen, and does it have to be bioidentical, or is the synthetic okay to take?
Well, it's going to be a difficult question to answer without knowing more specifically about the individual. When you have an estrogen receptor positive cancer, that is considered in general a contraindication to going back on hormones. That said, it really depends on the individual and exactly what was going on with the cancer. For example, with endometrial cancer, many of those cancers are detected very early, and it's really not deep into the muscle. And it's clear that the individual after the hysterectomy is cured. There's no metastatic disease. The lymph nodes, or if they were even needed to be sampled, were negative. And in a woman like that, it really becomes a personal individual decision if she wants to go on hormones. The whole risk of going on hormones after endometrial cancer would be if, in fact, there was some little spot that actually had spread. Because if it's in the uterus is removed, there is no more cancer. So it has to be individualized with really informed consent. So it would be generally thought to be contraindicated. But that said, individualization is important. And in some cases, it is okay. Some doctors, like oncologists involved with gynecological cancers, prefer to, even for the milder cases, to give it about 5 years and just make sure there's no recurrence for the next 5 years. So it is a complicated situation. So it's always painful when women have these contraindications that arise, like with a cancer. So when this happens, if that individual truly is contraindicated, at least for 5 years, to stay away from hormones, then you have to pull every other trick out of the hat to keep those bones healthy by really incorporating, everything with lifestyle, with the diet, with the exercise, with the circadian rhythm, to keep inflammation down in the body, and to eat all those amazing phytoestrogen foods, which may have some benefit, but they certainly have benefit for overall health. So you do everything that you can to maintain a healthy body, which will help to maintain healthy bones.
So, Dr. Gersh, in terms of, I know this is something part of your programs and what you preach, what would you recommend in terms of the phytoestrogen food? Like, what do you typically tell people?
Well, it's interesting with bone. Most of the bone benefits come from estrogen receptor alpha, but nothing is exclusive. Everything is complex and they always are interactive, but it's more, different organs have a more predominance of one receptor or another in general. So it turns out bones are more the alpha receptor, and many of the phytoestrogen foods that we eat are more the beta. So for example, soy. So soy works more on the beta receptor, which is found in other areas more predominantly, like in the GI tract. So, we just have to realize that these are not estrogens, they're plants that just happen to have these incredible molecules within them that can actually bind and act on our receptors. Soy is the one that we eat the most in terms of the beta, but also there's flaxseed. And flaxseed is also more the beta. And it's a little bit different though. It's a lignin. So it has a little bit different type of phytoestrogen. And my feeling is include them all, so try to include 2 tablespoons of the flaxseed every day and about a cup of organic whole soy. So for example, you can use a cup of edamame, that's the soybean. And there was an article that showed that if you eat that for a month or even up to like 12 weeks, it may take some people, you can actually suppress virtually close to all of the symptoms of hot flashes and night sweats, which do correlate with bone health, by the way, and heart health and brain health. So, because it's all interactive. Now, one of the phytoestrogen foods that's hardly ever talked about is pomegranates. So pomegranates have ellagic acid, which can turn into urolithins, which can act on estrogen receptors. So if you can get pomegranates whole or pomegranate juice, that would be potentially beneficial. And also resveratrol, which comes from, like, for example, red grapes. So that is also a phytoestrogen. So I would try to include all of those foods, but then recognize that there are many foods that really haven't been investigated. We don't really know all the different actions of their magical sauce, I call it the polyphenols, and how they interact with estrogen receptors. So eat a variety of every color of the rainbow, all the different colors of fruits and vegetables. And don't forget to do everything to sustain a healthy gut microbiome, to not have a lot of inflammation. So make sure you eat things like whole grains, not processed, not powderized, whole grains and beans and lentils and all the legumes. So all of that will really help to maintain strong bones. And in fact, don't forget the protein component. Remember, bone isn't just about minerals, it's also about the health of the protein matrix, kind of like the trunk of the tree that has the leaves and flowers on it. You want the whole thing to be healthy, and you've got to have that healthy protein matrix. So it's been shown that a lot of plant-based proteins can actually be, in some people, more beneficial than animal. So we want to have some of both, but we really want to emphasize the plant-based proteins, which are often neglected. And those are found in often the legumes, the beans and the lentils, which are so beneficial. And then also nuts and seeds are also really, really good. So make sure you eat plenty of plant-based proteins and some animal protein as well. You might want to also do a protein shake that you can get from pea-based protein or even rice-based protein, so that you can add extra protein, like say 20, 30 grams as an extra on top of everything else that you're eating, to really maintain that integrity of the protein matrix. And all of that will really serve you well.
Oh, what a fantastic answer. So let's just review that for a minute because there was so much good juice in that, Dr. Gersh. Okay, so 2 tablespoons of flax is what you recommend. Is that correct? Did I
Correct.
get that right?
Yes.
Okay,
Yes.
and then 1 cup. That's so interesting. So 1 cup of edamame, obviously organic. We don't want GMO,
Right.
correct? Okay,
Right.
and then the pomegranates. Is there, I guess, people have to be careful with blood sugar too, if they have an issue, but is there amount of pomegranates you tell people, or just throw it in your diet? What's your thought?
Well, I would say, like, if you get one of those nice big round ones, like
Yeah.
about a quarter of one a day. Now, if you eat the whole thing with those little seeds inside, that actually adds a lot of fiber. So, and if you do the juice, of course, you lose all the fiber. So if you can eat the whole pomegranate, then, the seed, including, the whole little red thing with the little seed inside, that is the best way to do it. But if you get the juice, don't do it as just a standalone. Do it as part of a meal, because that will lower the glycemic load. So that if you have that along with some healthy fats like nuts or avocado and some like healthy oils, that will help to lower the sugar effect. So you don't just like sit around and eat, have a giant glass of pomegranate juice by itself.
You know what I do? Trader Joe's has them already, because I used to buy the pomegranates,
Oh,
but Trader Joe's has organic pomegranates and they have it already. They've taken out all the
oh,
seeds for you. So you just have all those seeds. So you have the fiber, you have
yeah.
everything, and all the work is done and your hands don't get red. So, sometimes if you're going somewhere and you eat a pomegranate, unless you wear gloves.
Right. Right.
So that's certainly an easy way to do that. I don't even know how much constitutes, a whole pomegranate, how many seeds, but
Well,
that's probably,
figure like a quarter of a cup.
yeah, that's what I was thinking. Oh, that's
Yeah.
great.
But
And
and remember those beautiful colors that are making your hands all red inside of you. That's like the magic sauce that has all those magical polyphenols.
yeah, it's so that's one of my favorites, actually, the pomegranate. And then the other thing that you mentioned was resveratrol. Now, do you recommend for people also taking that as a supplement for the people who cannot take, for people who, as you said, who are not going on estrogen? Is that something that you would recommend as a supplement then?
Yes and no. The reason is that to get actually a lot of the benefit, they've
Mm-hmm.
shown that the amount you have to take is really, really high. And most of the supplements that are sold with resveratrol, because it's actually quite expensive, they have some, but it's probably not anywhere near the actual amount that you would need if you were going to take it to actually do a lot of benefit. But it's still better than not. So I don't have a problem with taking resveratrol, but they've done some studies like in women with polycystic ovary syndrome. And to get really the major benefit, you have to take, what might be like 10 times the amount that you would normally get in an average supplement. So, it's just one of those things where it's really hard. And that's why they used to say when they first discovered resveratrol, well, that you can get it from wine, red wine. It's like, hey, that's great. I'll have some. Well, then they say, but you have to drink a case of it, to get enough. So, it's just one of those things where don't do that. Do not drink a case of wine. But, if you get it in regular normal quantities from food, it is going to be beneficial. So I happen to love red grapes, and I have this amazing recipe where you use red grapes and garlic and the herb thyme and Brussels sprouts. And then you mix it all together with some olive oil, and you cut the Brussels sprouts in half. You put it on a baking sheet. You put it in a hot oven, like 425 for maybe 20, 25 minutes. And the red grapes are like so delicious. They're like caramelized, but they're not sugar. They're just really grapes, with all the benefits. And so there are many ways, and look for new recipes so that, maybe you don't want to just sit there and eat a bowl of grapes, but which, some people love, but, you can actually use them in salads and cooking, and all of that is great. And there's no harm in taking the supplements as well. But, you just realize that many of them have very small quantities of resveratrol because it is such an expensive product to create.
That's such a good point, because a lot of times you hear something and then you'll see a supplement. Oh, it has that in it, but it has barely any in it. So
Yeah.
I think that's a good point that you brought up. Wow, that sounds really, really yummy. Oh my goodness, these are such
Yes, you
good.
have to try that if you like
Yes,
Brussels sprouts. And if you don't like Brussels sprouts, try it because then you will like Brussels sprouts.
it sounds like you could probably even make it with other things, right? The combination
Oh,
sounds delicious.
sure. I think you could probably do roasted any vegetable.
Yeah. Okay. Yum. So, on that note, another question that just ties into what you said. So, my doctor told me years ago that soy disrupts healthy thyroid function and to avoid it. I'd love to know if this is just as false as other misinformation I was given. And then it's parentheses, when I was told I couldn't go on HRT at 57 despite having osteoporosis because the risks outweighed the benefits. So that's what one person from the summit wrote in. So what's your feeling on that about the thyroid and soy?
No, you would have to eat like pounds of the soy to have any impact. So do not worry about that, your thyroid gland and soy. And so just enjoy. I'm not asking anyone to eat more than 1 cup a day, and it doesn't have to be every single day. And you can also use, so not just edamame, you can use tofu, miso, or tempeh. You shouldn't use soy burgers or soy hot dogs. We're not talking about those kinds of manufactured foods. So no, do not worry. This is not going to be your problem. It's one of those things where I always talk about people are afraid of the wrong things. Like they're afraid of organic soy. No, do not be afraid of organic soy. Be afraid of endocrine disruptors, like the chemicals in food and in the air and in the water that actually act as thyroid endocrine disruptors and disrupt the way the normal thyroid works, not this whole natural organic food. So it's just one of those really unfortunate things that instead of educating on, well, don't cook and microwave in plastic and look at what you're eating, look at labels, and hopefully there aren't labels, right? Because if it's from the farm, it doesn't come with a label. If it comes from a store, maybe it has a sticker that says organic Fuji apple or something like that. But so look at those things as really very toxic things that can get into your body that interfere with thyroid function, not soy. So like, don't be afraid of the wrong things. Don't be afraid of soy. Now, regarding the question about, 57 and the risks are so great, that just drives me crazy. We talk about this all the time, that's the legacy of the Women's Health Initiative that has so brainwashed doctors and the public into fearing, once again, being afraid of the wrong thing, instead of embracing hormones and recognizing, how weird would that be? That our own hormones were put in our bodies to kill us. The whole premise of it is so weird, that we have natural hormones that actually sabotage us. No, it doesn't work that way. What sabotages us is giving chemicals and then calling them something they're not, like giving medroxyprogesterone acetate and then calling it progesterone, giving conjugated equine estrogens orally and then calling it, estrogen, using that word as if all estrogens are the same, when estrogens are a family of hormones. They're not all one thing. So, I keep getting back to, if you test something in any form or fashion, the results apply to what you tested, not to what you didn't test. You tested this. That's the answer, is this gives you this result, not that. So they didn't do a study with human bioidentical hormones given in a way to get it into the bloodstream and the tissues as human identical hormones. But then they got a conclusion that wasn't even all that bad, to be honest. It was like not really as bad as people even think. And in fact, in women in their 50s, it showed, even using those weird non-human hormones, that there was a 30% all-cause reduction in mortality. In other words, whatever you can think of that someone can die from, there was a 30% reduction in death from that, whatever. And that sounds weird, but that is the result. So you either take a study with all of the outcomes, or you throw the whole thing in the trash can. You can't cherry pick, well, I'm going to believe this outcome, but not at that outcome. It doesn't work that way. When you do a study, it sinks or swims as a whole. So if you look at the Women's Health Initiative, in women that were in their 50s, which only made up 10% of the population that they studied, because you weren't allowed to have any menopausal symptoms because they didn't want women to try to figure out if they were on the hormone or the placebo. But of course, they all figured it out anyway, because they had so much breast tenderness and some of them had bleeding. I mean, they all figured out what they were on. It was completely unblinded, even though it was supposed to be blinded, because they all had symptoms that told them what they had or didn't have in the pills that they were taking. But they used only 10% of the population of patients that they studied were in their 50s. But of that group, they showed no harms. They showed nothing bad. And they had 30% reduction of all-cause mortality. In the women who were older, like 60s and 70s, it really only showed a small increase in stroke. And that was predominantly because the formulation that they used increased blood clotting by 400%. Well, that's huge. Now, when you use transdermal estrogen through the skin, you do not impact blood clotting at all. In fact, healthy levels of estradiol actually modulate the platelet functions. So it actually prevents just random blood clotting in the body. It wouldn't do that. You know, that's why older women are much more likely, not on hormones, more likely to get blood clots than younger women. But women on birth control pills are more likely to get blood clots because they don't have human hormones in their bodies. They're getting these exogenous outside hormones that are converted to estrone, which is a sort of an activator of the inflammatory process, because estrogen like regulates it. So it turns it on and it turns it off. When you only have one form of estrogen, it just gets it stuck in the on mode. You don't have the way to turn it on and off. You just get stuck in on. You know, like the gas is on and you can't like put on the brake. So, you know, that's why you can't compare the outcome when you don't use human bioidentical hormones. Also, you have to use them in a dose that's going to get levels in the body that will be similar to the levels that a healthy woman would have. It would be like saying, you know, vegetables are useless. Maybe they're even bad for you. But then when you do look at the results of the study that they're referring to, they had people eat one bite of vegetable a month. So it's like, well, what is that going to tell you? Nothing. So if you give hormones at a level, that a dose that gives a level that is not even different from having no hormones in the body, you know, taking it, that's what they did in some studies. They gave doses that were so tiny that it didn't even budge the meter on your hormone levels. It was ridiculous. So this is the problem because of the legacy. Even the follow-up studies that they did with other types of hormones, they used such tiny doses because even the people doing the studies were afraid of hormones. They were afraid. So they gave tiny, tiny doses, and everything is dose responsive. You know, if you give nothing, you're going to get kind of a nothing result. And so the bottom line is that hormones are amazing. One of the things that did come out of the Women's Health Initiative regarding bones is that there was over a 30% reduction in fracture risk in the women on those, I call them phony baloney hormones, because they're really endocrine disruptors. They're never found in a human body. So you can call them hormones, but that's not so different than calling plastic hormones, because we never would find plastic naturally in our bodies, and we would never find those hormones naturally in a female body. But whatever you want to call them, you know, pseudo human hormones, whatever, they actually still had benefit in that they actually significantly reduced fracture risk in those women, which is pretty amazing. It also lowered colon cancers, and it increased breast cancers tiny, tiny amount, like barely statistically significant. And that only held with the women who were on the phony baloney progesterone, the medroxyprogesterone acetate. The women who were only on the estrogen formulation actually had a lower incidence of breast cancer, although it didn't quite make statistical significance. So the bottom line is, even the stuff they used in the Women's Health Initiative really wasn't all that bad, and it actually showed benefit for bones and for the colon. And one of the reasons they stopped the study was because there were so many women dropping out of the study that if they kept on, you know, honestly, this is like a behind the scenes kind of a thing, because if they kept on with the study, and people continue to drop out at the rate they were dropping out, they would have lost so many women that they would have lost their ability to run a reasonable study because the numbers were dropping and women were realizing what they were taking. So there was like a sort of a funny reason why they stopped it, because the study was not going to be valid if it kept going down the road it was going down. And then, but they said it was because it showed already after just those few years more harm than good. But we don't know 100% that even is true because they stopped it. So, it's just a challenging kind of a study, but it has really very little to nothing to do with a woman using human bioidentical hormones at physiologic levels. So there, in my opinion, getting to the final answer of that question is I would give hormones to that woman unless she had some real clear contraindication, because the benefits, in my opinion, clearly outweigh the risks, clearly.
Wow, that was just such a meaty answer with so much good information. And I agree with you. My husband's an OB-GYN, and he said years ago when they were prescribing, and again, it was the synthetic, that what you're talking about, but they didn't have the osteoporosis that they have today because people were, it had a major protective effect. So absolutely. So, but
that's right.
Yeah.
Because the hormone that was given, the conjugated equine estrogens, it turned in the blood to a variety of things that comes from a horse, but also into estrone. And estrone works predominantly on the alpha receptor, which is the main one in bone. Now, unfortunately, the alpha receptor is also the main one on immune cells. So it also can create a little bit of overactivation of the immune system, which can create a pro-inflammatory state. And it doesn't work on the beta, which is the one in the gut that keeps the gut healthy. So it's just not what a human female ever has, but it did have that sort of, at least some benefit. It did have something good.
Yeah. So it's just very interesting. And it's just so sad, as you said, that the results were misinterpreted, and it really changed everything. And every single doctor really, worldwide just stopped.
Worldwide.
Yeah, completely stopped and changed, and changed their plan on how they managed osteoporosis with different drugs. So there was really,
but happily, it got in under the wire. So one of the FDA approved uses of estrogen is for bone health. So that's like a really key thing. The North American Menopause Society, which is a very long-standing, very conservative organization, they put out a new position paper back in 2017. So it's already 5 years ago. And this was, for me, groundbreaking what they did. And I can tell just from reading the whole position paper that there was a lot of controversy going on when they came up with this. But they actually said that you can use hormones forever with no end date, no stopping date, your whole life, for the following 3 reasons: for suppression and control of menopausal symptoms like night sweats and hot flashes, for bone health forever, and for quality of life. So that was so clever, because that covers the FDA approved uses, plus that sort of nebulous, in the ethers, quality of life. So it really gives me a firm footing to allow me to be mainstream, although it's not mainstream, but it could be mainstream because they're a mainstream organization, to use hormones for women forever, for those reasons. So that's, for people who have doctors, let them know what the North American Menopause Society said when their doctors say, oh, now you're 60, so you're too old to be on hormones. No, you're not. I mean, when you stop hormones, you start the clock really like tick-tocking really fast, and you start losing all the benefits. So, there's nothing that says you're too old, you're 60, you're 65, now you're too old for hormones. No, that's nonsense. So, why would you say, now I'm too old to be healthy? So instead, you're going to go on drugs for depression and hypertension and, statins, and, you're going to go on, and bone, drugs for bones. So instead of just staying on your hormones and having everything sort of properly managed the way nature wants it, nature doesn't really want you to be old. I mean, that we just have to accept that. We want to get old, but nature says, you're done. But, so we come up with these clever ways, but pharmaceuticals are clever too. But why end up on 5 pharmaceuticals when you can just be on bioidentical human hormones and maintain all the organ systems working happily and then not have to go on all those pharmaceuticals? At least that's the way I see it.
And that's what you've been doing in your practice. You've been doing this for quite a while.
Absolutely. And I have a vascular ultrasound tech because, I love data. So I love for my women when they get around menopause to have some baseline studies. So you know where you are when you're starting menopause. It's just like with bones. How do you know that you lost bone if you never found out where you started when you hit menopause, right? Did you lose it or did you never get it because you never built it up properly in the first place? So I like to get my baseline studies to see where we're starting, and then we can keep an eye on everything. So I like to get vascular scans. So we look at, the carotid artery, the aorta, the leg arteries, and my ultrasound tech, she travels and she comes to me like just once a week for one day. And because she goes to different offices. And she says, I can't believe your patients, like they're the healthiest. They have totally different arteries than all the other doctors because you've been taking care of them. They've been eating healthy and exercising. And when she checks them and they're like 65 and they've been on hormones since they were 50 and they're looking really healthy. Their arteries are looking good. And then she goes to another office and does a 65-year-old and it's like, like trouble. And it's just, I'm seeing the results of what we're doing. When you do everything, you don't just take hormones and eat garbage, of course not, but when you try really hard with a few days of exceptions, right? But you try to eat all the right foods, you try to sleep at the right times, you try to move and have fitness and purpose and love and sunlight and all those good things and lower toxin exposures as much as you can. And then you maintain physiologic hormones, your cells have what they need to do their jobs. I always say cells in your body don't know how old you are. Like the cells in your skin are not the same age as the cells in your bone or the same age as the cells in your heart. They're because cells replace themselves at different rates. So the cells don't know how old you are. They don't think, oh, I live in Jane and Jane is 62 years old. So Jane is just old and I'm not going to behave myself and do what I'm supposed to do. No, the cell says I'm genetically programmed to do X, Y, Z. If you give me the right nutrients, the right hormones, I'm just going to keep doing X, Y, Z. So now we can't totally maintain everything the same when you're 62 as when you're 22, but we can come closer than if we don't try at all and we don't give the right hormones and the food and everything else. But if you give all the cells what they need to do their job and you give them the hormones, which is really the directions. If you think of hormones as the cell directions, it's a communication system and it says, do this. And then they have all the ingredients to do this. They'll do it at any age. So it's amazing what you can actually do to manage age. So we don't call it anti-aging because, that's just not possible to be anti-aging. That's so negative sounding.
Yeah, me,
anyway.
I feel,
Yeah.
I'm into happiness. I don't like the term either, Dr.
Yeah.
Gersh. Yeah.
So it's age management, like everything in life, we want to manage it, right? So we want to manage the fact that every year we get older and we want to manage it in a way that's rational, scientific, and feasible. And that's what, that's my goal, is to let every patient I see have the optimal function, the optimal health that they can possibly have so that they don't go down, I call it, the dark rabbit hole of conventional medicine, ending up with all kinds of pharmaceuticals and procedures. And women in particular, genetically are programmed to live a little bit longer, I think because we have that extra X chromosome that makes us extra special, but we do live a few years longer statistically, but we live with more chronic disease, like osteoporosis, osteoarthritis, dementia, and we have ultimately more heart attacks, more strokes, more ruptured aneurysms after the age of 65 than anyone ever realizes, and it surpasses men in many cases. So it's not a great life once you hit 65 and over if you don't do all the things that you can, that are available, so that you don't end up in a chronic ill and chronic pain state, especially pain, because so many women have chronic states of pain, and that's not a quality life. So, if you have like osteoporosis involving your vertebra and you have compression fractures, that is a lifetime of pain. I mean, it changes the quality of your life as well as potentially the length of your life when those kinds of fractures occur. And they're so common in women over 65.
Wow, I want to get to people's questions, but I have so many to ask you. So before we go there, so in terms of your practice, so I think people want to know, because there are people listening who may be 65 and they're like, so she's telling me that I can start bioidentical hormones now, correct?
Well, the official thinking is that once you hit 10 years after the onset of menopause, which is officially 12 months of no periods, consecutively, that it's too late. You've missed the boat. But the reality is that if you look at the Women's Health Initiative, women who started who were well past 10 years still had benefits in terms of reduced fractures, reduced colon cancer. And we don't have long-term data. We just don't have it, because after that study, the follow-up studies were short-term, and the only one that actually looked at benefits or potential lack of them in women who were at least, say, 10 years after menopause used an oral estrogen in a very small dose. They used the wrong thing. So I don't know, so this is how I think about it. By the way, in that one study, they showed no harm. So that's like sometimes that's the best we can say from a study is it showed no harm. Okay, so that's good. So at least, that Hippocratic oath, do no harm. Okay, well, it showed do no harm. It didn't do anything bad. It just didn't seem to do anything good. But they were once again using too small a dose and the wrong form of estrogen. Well, what about the tissues that we do know that have been studied with estrogen long after, like more than a decade after menopause? Well, the biggest one that has data is the vagina. So it's advocated to use estrogen vaginally, or even DHEA, which can turn into estrogen by the cells, that to use estrogen for vaginal health at any time after menopause, whether a woman is 50, 60, 70, 80, it doesn't matter. There's no contraindication. And in fact, it's strongly encouraged that women can start vaginal estrogen at any time. And guess why? Because they show benefits. Okay, so the vaginal tissues get better. Now, do they turn into 20-year-old? No. But do they get better? Yes. Okay, and significantly so. So here's the thing. Is there something totally unique about the vagina that only the vagina would respond to hormones and show benefit after 10, 20, 30 years after the onset of menopause? That's irrational to think that. Why would nature do that? Nature didn't even know you were going to get hormones when you're 70 in your vagina, right? So there is no plan. That's just that the receptors are not completely like offline. The receptors are still capable of responding. That's the concern. It's kind of that old use it or lose it kind of philosophy. Like if you don't have anything useful going into the hormone receptors, they kind of get the equivalent of human rusty, right? And maybe they do, but maybe you have to work with them longer to get them back online. Maybe they're not perfect, but anything that's better is still better. Okay, we can't accept perfect as the only solution. How about just better? So what other tissue has been shown to respond to estrogen long after menopause? The skin. So I did some research on hormones and skin, okay, and wound healing and wrinkles, okay? Well, back in the 1990s, remember, they closed down the Women's Health Initiative around 2002, okay? So back, in the previous decade and in the early 2000s, there were studies coming out of giving hormones, estradiol, to the skin, not, the face and other skin, and they found significant benefits for wound healing because estrogen creates growth factors and it helps heal. I mean, estrogen is all about healing and growth, but in a controlled way when everything is right, of course. And They showed reduction in wrinkles, wound healing improvement, and all those studies shut down after the Women's Health Initiative. But in the 1990s and just into the very early 2000s, because those studies were in process when the Women's Health Initiative shut down, there were a whole slew of studies showing really significant benefits of estrogen to skin health. And these were women who were out of menopause for many, many years. So why would the skin and the vagina be the only tissues that respond? It doesn't make sense. And we know that the bone did better in the Women's Health Initiative and the colon did better. So my personal philosophy is, if the one study we have, one study shows no harm, then I feel comfortable with giving informed consent, telling people where we are and so forth, to say, okay, I don't know how much benefit we're going to have for your, for your heart or your arteries. But the other thing is Dale Bredesen. I don't know if people have heard of him. He did the Reversing Alzheimer's whole program, and he gives estrogen to all his women with mild cognitive dysfunction and worse, into the full-blown Alzheimer's. Every one of them should be on bioidentical human hormones, all the women. He puts on hormones. And I remember seeing years and years ago where they took brain cells and put them in a solution with estrogen and another solution without estrogen. And the ones with estrogen looked like a lush forest, and the ones without estrogen looked like dead sticks. And I said, which brain do I want, the dead sticks or the lush forest? I'll pick lush forest. Okay. So the estrogen helped, restore neurons. And now this is like in a test tube. But you know what? We have Dale Bredesen using hormones in older women. We have vaginal and skin health data. We have a study showing no harm. So I will do it with informed consent, but not too many doctors will, to be realistic.
Okay. That was a really great answer. Thank you so much. So someone else asked, I have more questions to go for that, but I want to answer some of the questions that people gave, at the summit. Are you able to give names of human bioavailable estrogen products you recommend?
Sure. So there's not a slew of them anymore. A lot of the ones that came out years ago all disappeared. The companies folded or they just stopped making them. So we don't have that many to choose from. The commercial brands, there's the patches. Now, the original patch was, the branded name was Vivel, and then that was an alcohol reservoir patch. And then they refined it into a different system that's like a matrix. So instead of sort of a big fat rounded patch, it was like a very small flat kind of a little patch. And that was then renamed Vivel Dot. And then a variant of that came out that was called the Minivel. Nowadays, most of the estrogen patches, and they're all estradiol. They have the right type of estrogen in them. They are now the generics. And there's a variety of generic companies that put them out. Like one is called the Dottie. Like DOTTI, but you can't even control what generic you're going to get. It's like whatever the pharmacy bought, or the mail order, so the most of the time you have to really, if you really want the branded product, which by the way, I do think is superior and more controlled, but in order to get that, you have to go through prior authorization or you pay even a lot more money. And most women now use the generic patches. So they would just be estradiol patches, but those are the brand names, Vivel Dot and Minivel. Then we have gels. There's only 2 gels that are out now marketed. One is called Divigel, and Divigel comes in little packs that each pack you open up, and what you press out the estrogen gel that's in the little pack, and each pack is a single day dose. So you take that gel of estradiol, it's all estradiol, and then you wipe it onto your anterior thigh for the Divigel. So you just wipe it onto clean, dry skin every morning, and that's your dose of estrogen for the day. And then the other gel is called estrogel, and that's a pump. It has a pump, and you get a blob of gel that comes out of the pump, and you take that blob of gel and then you wipe it up your arm. You don't like rub it in. The gels you don't rub in. You just wipe it on and then you let it air dry. The same with the Divigel on your leg. You don't like rub it. You just wipe it on and to make it a smooth, wipe on, and then you let it air dry. So the estrogel is a pump, and most women in the US use one pump. In Europe, they usually use two pumps and put one pump on each arm, which gives you a better therapeutic dose. So most of my women use two pumps, but some use one pump. You have to see what the levels are after they use it, what comes out when you do a blood test. So those are the branded. Now, there's also a ring, which is really hard to get, called Fem ring. Now, don't get that confused with S-string. S-string is a vaginal estrogen delivery system in a ring form, but it doesn't get, it's the dose is so little, it's just for the vagina, and that's called S-string. So it's like a ring, like a little bit like the birth control, the Nuva ring, but it's not birth control, it's just estrogen. And so there's a very small dose, that's S-string, and then the higher dose is called Fem ring, and that is a vaginal ring, and it stays in for 90 days and you replace it. But it never caught on too well, and it was very expensive. It's not on too many insurances, if any, and it would probably be a special order if you wanted the Fem ring. And then that's it for the systemically delivered. There's other vaginal products, but they're just for the vagina. So we're talking about systemic, that's actually going to help bones and brain and arteries and that kind of thing. So
that's
it. And then the others that you can do are through a compounded pharmacy. So they don't have a name. That would just be that you work with a compounding pharmacy, and those can come in different varieties, but the only kind that I would ever use is cream form, that you use a cream and then you decide for each individual what part of the body you're going to put the cream on, if you're going to do it once a day, twice a day, and so on. So the compounded is very, very individualized.
So I think it's very important, though, while you're speaking, it's not something you really need to work with someone who's knowledgeable in this. Am I correct with who you're dealing with?
I think that's always preferable. Sometimes you have to, take what you can get, but, it's always better to have someone who actually knows all the options and is comfortable using them. But sometimes I know it's just hard to find a doctor that's willing to prescribe hormones these days. It's so crazy.
Okay, so we're moving on. I could talk to you for 10 hours, but I want to answer I want to answer people's questions. But actually, before I get to the next question, you had just mentioned something about the person who's had fractures, and that's an issue. There are numerous people who've written in that they've had compression fractures, they've had multiple fractures, their DEXA is minus 3.5 or lower. I know when that person comes to you, what is your feeling? Where do you start with someone like that?
Well, most of those people have been out in menopause for many, many years. And sadly, many of those women had surgical menopause. If you go back on there, meaning that they had their ovaries removed surgically at a younger age. And we know that that will dramatically accelerate bone loss. So those just break my heart, because in the old days, which weren't that old, because this is how I was taught. Well, if a woman is 40, certainly 45 or older, and you're going in for benign disease like fibroids, something like that, or just bad periods, and they're having a hysterectomy, and they were done like at the drop of a hat, like hysterectomies was like so common for like no particular reason, like, oh, well, I don't like my periods. I mean, it's ridiculous, but it's like you're 45, might as well just take out your ovaries, because then you won't get ovarian cancer, and who needs them? Who needs ovaries anyway? You're not having more babies, and they're just, trouble, and you never know, maybe you'll get ovarian cancer. So, I mean, to take out the ovaries of a woman who still has functioning ovaries in particular in her mid 40s, and sometimes people who go down to even age 40, is really catastrophic, we now know, for many organ systems, and definitely for the bones. So depending on how old the woman is and her situation, I would definitely seriously think about putting her on physiologic dosing of estrogen. But we have to be realistic. I mean, the bones that are already compressed or fractured, we don't have the ability. That's why we have to be so proactive. So it breaks my heart when people are already in an advanced state of osteoporosis. So there can be a place for some of the pharmaceuticals, but you have to realize that once these drugs get started on, we don't really have very good exit strategies. So I really, really hate to use those pharmaceuticals with people who are younger than about 75, because it means we don't have any long-term data on giving these drugs to women who are like 52 and so on, because like you can't, once you're on a drug like the brand name like Prolia, well, there is absolutely no exit strategy, but we know that if you go on that drug and then you go off of it, you have accelerated bone loss. That's even worse than if you were never on it. It's really catastrophic. So, and there's really no exit strategy. And so you really have to stay on it for life. So if you're starting and you're 75, well, you're just older. So it will be fewer years than if you started statistically and you're only like around 50, 52. So I really, it's just terrible when women they're 40, their ovaries are removed, and then they're 50, they already have really serious osteoporosis. But I would hesitate to use the drugs in anyone in that young age group because of what we're getting into without a good exit strategy, and that these drugs really change the bone and make it weaker in the long haul because you don't have proper bone replacement. I would rather really work with women with their diet and lifestyle and get them on physiologic hormones if they're in the younger group. In women who have really bad bones and fractures and they're 75 plus, I would definitely consider the drug Prolia. I think we have to also, there's another drug, Forteo, which also has only a short-term use. So Forteo works to actually build bone. Okay, so through the use, like through parathyroid. So it actually builds bone, but you can only stay on it for like 20 months because it caused cancer in rodents. So it's like one of those crazy things. So, and then if you stop it, then you lose all the bone that you built up. So then you have to have a strategy, and we don't have any data. There's just no data because no one did a study. Well, what if you take the drug that helps build bone and then from there you go on estrogen? We have no data. So we're just, creating our own program with no foundation except basic science, but we don't have any human data. So it's really a hard place to be. But the typical thing would be to use that drug and then go on either a bisphosphonate or Prolia. But, it's really, there's no great solution, but we do have to be as aggressive as we can. Definitely, you don't want to do nothing. You either, once you have compression fractures and a really, really low, or other fractures, and you have a really low DEXA score, you really have to think of going on hormones. You have to think about the pharmaceuticals as well as the lifestyle.
Yeah, because, a lot of people just under absolutely no circumstances do they want the pharmaceuticals. And as much as we want to be natural and do all the amazing things, which we know help bone, and we know there's natural approaches that are amazing. And, how important is balance and all the exercises, and so that people don't fall. But, you don't want to fracture again. And so I think that was really a good point. Okay, so we're going to move on. Let me just keep, is it okay if we just keep going a little longer?
Sure.
Okay,
sure.
Great. There's so many good questions. Okay. So someone also, let's just get back to the thyroid for one more. Another person she was interested in the thyroid connection, which we talked about. She's hypothyroid, with so many people with osteoporosis are, and so many women are, and have been told to watch out for goitrogens. And so she was just curious. She said, my antibody levels are okay, but my thyroid is not working well, even with medication, due to the vicious triangle of gut. She has SIBO, thyroid and hormone imbalance. So I'd be interested in your comments on this. But her big question was the goitrogen, I guess.
Okay, so that is really like a false flag too. So don't worry so much about those foods. Worry about getting in the good foods, and don't worry about eating soy, please. That's not really what's giving you problems with your thyroid. So, we really definitely, you have to think about what's going on when people have SIBO. So it could be they had a bad food poisoning, or they had, they had some kind of like a very big emotional stress, or they had some really serious, food allergy or something going on. But it can also happen just because you don't have hormones, because estrogen helps regulate the peristalsis, so that the way the gut moves things down. So sometimes going on hormones actually will really help with SIBO, because you can't just keep taking antibiotics or antimicrobial herbals forever, because you're killing off the good guys. You're not just killing off the bad guys. You can't just go on a killing spree that is endless. So you got to really look at why is someone having SIBO and sort of trying to correct the underlying thing, which often is peristalsis. So which can be affected by emotions, can be affected by hormones. And of course, thyroid is part of the whole hormone routine. So you really want to get your thyroid right. Now, there are a few different thyroid products. So you really have to work with somebody that's going to, really just intensively help. So for some people, they need to do a branded product for thyroid like Tyrosint, which has a liquid form, which is better absorbed. So maybe because you don't absorb it, maybe you have a gut problem, with SIBO and you're taking it, maybe, you're just not absorbing. So that would be a good reason to try Tyrosint, which is a liquid form, which is far more absorbable than the tablets, especially the generic tablets, once again, are not as good. And you have to beware using a desiccated thyroid, for example, like Armour thyroid or MP thyroid, because those are not time release. And you may take it and then suddenly all of it absorbs at once. And then you get hyperthyroid, which can promote bone loss. Okay, you don't want to have hyperthyroid. And then the rest of the day, you're hypothyroid, which can also promote bone loss. So, and you're like maybe good for an hour a day. So that we really have to be careful about too. So people who have really significant gut problems, it's usually best to stay away from the desiccated thyroid products because they're not time release and you never know how they're getting absorbed into your system all at once or not at all. And so I would go with more a product like a Tyrosint for someone who's having a gut problem, at least until it's resolved. And that can really help to manage the thyroid much better, because you definitely need to don't worry about eating foods, worry about getting the nutrients in from the foods by getting your gut working better and then getting the right thyroid levels.
Oh, fabulous. Now, you sort of answered this indirectly, but you can just briefly mention, there are a lot of people who have had cancer and they're on aromatase inhibitors, and which causes reduction in bone loss, which causes bone loss. And so what's your feeling on a young person who's on, who had cancer and they're on aromatase inhibitors?
Well, once again, that's a tragic situation for which there is no great solution. What most of the time, but not always, aromatase inhibitors are used in postmenopausal women, but not always, because nowadays they'll get very aggressive with younger women and they'll basically get rid of their ovarian function by giving drugs that block the ovarian function at all, and then add the aromatase inhibitors. So they didn't used to do that, but now they're doing that more. And those women are going to almost be guaranteed to have bone problems. So you really have to talk to the oncologist and say, okay, what really are the odds? Like I was talking to a patient just about a week ago who was put on aromatase inhibitors with a breast cancer. So that woman was told, well, if you go on aromatase inhibitors, you are reducing your risk of recurrence by 50% in your case. It's like, well, that sounds huge. I mean, who would say no to that? Nobody wants to die of breast cancer. A reduction of 50%, that's huge. So I said, okay, but what are the real numbers? What are we talking about? What's your risk of recurrence based on your particular type of breast cancer, the amount, the type, the aggressiveness? Well, when she went back and asked, her chance of having a recurrence was 4%. Her chance of having a recurrence on aromatase inhibitors was 2%. Okay, that may change how somebody views it, right? So, well, that's a 50% reduction. Who would say no to that? But then, 4% to 2%. So you got to get the real numbers. Don't just hear those crazy percents, because you need to make your own decisions. You may say, okay, everything is about risk benefit ratio and where your tolerance of this and that kind of risk is. So you may say, well, my biggest fear in life is recurrence of breast cancer. I'll do whatever it takes and I'll just live with what other consequences of these drugs like aromatase inhibitors. Or others will say, you know what? I know my breast cancer was really tiny. It wasn't a high grade lesion. I don't have positive lymph nodes. And I don't want to be on these drugs for years and years. Now it was 5 years, now it could be 10 years, So basically it's devastating to, the many organ systems, including the musculoskeletal system. And they say, you know what, I would rather take my chances on the breast cancer because the risk is really statistically low, just as is. And I would rather feel better, not have all the negative effects of being on aromatase inhibitors and having no estrogen in any organ in my body, not just, organs that are at risk, but like every organ has no estrogen. And I would rather just take the risk of the breast cancer rather than the risk of all the adverse events of the aromatase inhibitor. So each case has to be looked at very individualized, and you really have to go to the oncologist who you're working with and just say, I don't want to hear it's a 50% reduction or whatever. I want to know the real numbers so I can make my own decision. And then you make what feels right to you, because that's what life is all about, just taking your best guess at what's the best for you. But you can't make your best decision if you don't have really, the best numbers to work from that are real. Okay. Not just, abstract, like 50%. You don't know 50% of what,
Yeah, that's a good point. Even with a lot of the other medication where they'll say there's 50% reduction in fractures, but maybe it's, look at exactly what it is, because it can be very misleading. And you think, oh, wow, I'm really preventing things. And it's just like you said. So yeah, that's such a very good point.
That's a big game that big pharma unfortunately plays,
Yeah. So I think that's
just
really,
think about this. If the incidence is 1 in, we'll say 2 in 10,000, and you take a drug or you do something, and the risk goes from 2 in 10,000 to 1 in 10,000, that's a 50% reduction. But then, maybe you'll take your chance at 2 in 10,000.
Exactly. Exactly. And I think the other thing that's so important for these people is just to do everything else that you talk about, that I talk about, do everything if you're on these for your bones. Okay. So I'll just give you one more question because we could be here for so long.
Okay.
If that's okay. There's actually, how about 2? Is that okay?
Sure.
Okay. We'll do. So this one was asked by Trudy Scott, who's a nutritionist, and she does all sorts of work with anxiety. She's an anxiety expert, and she loved your talk. And she just thought your message was so important for young girls who are on the birth control. But now she asks, should the women who are on birth control for 10 to 20 years do bone density tests much earlier? And if yes, like when would you recommend that?
Well, we don't have any data on real what it means when you do it in a younger age group. Although we do know that you probably, will be peaked out on your bone density by age 32, and most of your bone is actually accumulated in the late teens and early 20s. It's actually more concentrated into that age group than we realized. But I don't typically get a bone density in anyone that isn't perimenopausal or in that range. And just because I don't know that I'm going to do anything differently or educate differently from that, I don't see any real harm. And there are people that are getting them earlier, like if they were on, say, drugs, for example. If a woman has endometriosis and they use basically like aromatase inhibitors and they block the production of estrogen in women who have these unfortunate conditions, like they're not cancer, but they're like endometriosis. And now they're giving estrogen blocking drugs for uterine fibroids. So those women have dramatically higher risk of also developing osteoporosis. So we haven't accumulated a lot of data on doing bone densities in younger women to say, oh, for sure that what this means. But recognizing that the radiation level is so low with the DEXA scan, if somebody really wants to have it done, I would just assume that they don't have optimal bone based on the science. But if they want to see it, but understand that we don't have a lot of data on doing bone densities in like 38-year-olds or, that type of thing, then I don't see it as a huge negative, but I typically don't order them in women in like their 30s or even younger.
Okay. And she wanted to know, is there anything you know about reversing the impact on bone health later in life? Like, can they catch up for the people who are on birth control pills for all those years?
They will never catch up. But that said, we can do better. Once again, perfect is probably not on the horizon, but we can do better. So it's thought that, well, you can't really build bone much after you hit peak bone mass, and you're just into like stabilization. Let's not lose any. But there are actually some data that you can build some bone. So I'm not giving up on anyone just on the, so, I would say, and I would never want to be negative. I would say, you know what? There's a chance we could build more bone, but we can certainly build better muscle. We can get great, balance and strength. And, we can do some bone remodeling once you're not on drugs that block, building bone is part of building good remodeling. So we should do strength training. We should have the perfect diet as much as possible. And we should make sure that hormones are optimized forever from that point forward. So we can do a lot. Maybe we can't have ultimately the same bone that would have been there from if none of those pills were or hormonal contraceptives were ever used, but we can do better. And I do believe in my heart that we can still build more bone.
Oh, and I see that. I mean, both of us see that all the time, that people live their lives and they've never been stronger. They've never been healthier. So it's just such a win-win when you start doing things for your bones that affect every aspect of your body. So I don't think there's just one question on milk. You don't have to go into this in detail, but someone said she enjoys 2 cups of milk daily. And she just wanted to make sure, she said you mentioned avoiding too much milk. Did you want to just say one quick thing about that?
I would stop it. I do not like the idea of 2 cups of milk every day. Now, that said, if it is from an organic cow and it's, really clean but unpasteurized, and so it has the cow's probiotics and it's full fat, maybe it's better. But where do you find milk like that? In fact, in my state, California, it's illegal, so you're not going to get unpasteurized milk that has the actual probiotics. And most cows are coming from feedlot farms and stuff, so it's just what it is. And the advent of the enormous dairy consumption has paralleled the decline in bone health. So remember, the calcium there's plenty of calcium in milk, but it doesn't get into your bones anything like the calcium that gets into your bones from eating leafy greens. So, definitely I would, if you really love it, why don't you cut it in half? I personally love organic, it's whole soy milk. So try some of the nut milks, so I have patients that love hemp milk, and that's not, that's a grain milk. And then they like, cashew milk and macadamia nut milk. And, I just love the soy milk, which also has a lot of protein. So try one of the others. And, it'll grow on you if you, try it for a while. Maybe try cutting down to 1 cup a day and then see where you go from there.
Oh my goodness. So I know I can't thank you enough. And, tell everybody where they can get in touch with you. And you have your Instagram is great. You have all sorts of wonderful things. And then we can also, in the show notes, I know you have an ebook as well. So just tell us what's all possible and how people can stay in touch.
Well, yes, I'm giving out a free ebook on menopause. I hope everybody would like to get a hold of it. And in my practice, I see patients every day, Monday through Friday, except when I'm like in another city giving a lecture like today. And so right now I have my books. I have my newest book, Menopause 50 Things You Need to Know, that's out there on Amazon. And like you said, my Instagram, and more things will be coming. So stay tuned. But right now, that's where I'm at, and I'm pretty busy doing all of that.
Oh, well, you've just made such a contribution, and you've helped so many people on the summit and people worldwide. You are just such a wealth of knowledge, and you share it, and you really, you've taken the research, what's out there, and put it into manageable things that people can do to really, really change their lives. So I just can't thank you enough in all your books. And I'll have all the links to everything in the show notes for everyone, as well as I'll keep in touch with everyone who, anything new that comes up, we'll certainly share. So I can't thank you enough for taking all the time and answering all these questions.
Oh, my pleasure. Everyone stay strong out there.
Thanks again. I hope you enjoyed my interview with Dr. Gersh and now have a better understanding of estrogen and how it can be utilized to improve your bones and overall health. All the links Dr. Gersh talked about will be in the show notes. Plus, if you didn't get to attend the Natural Approaches to Osteoporosis and Bone Health Summit, you can still watch it for 7 days. And so I'll give that link below. So thanks so much for tuning in, and I look forward to seeing you on the next episode.